Hi guys, Dr. Rahul this side, and as you can see in this slide that today we will discuss about anti-cancer drugs and their side effects. An important a topic for your exam, and as you know that it is very difficult to remember the drugs and their side effects, right? So we will approach system wise. For this I took this diagram, and in this diagram itself I will try to discuss about the anti-cancer drugs as per system, and also their side effects in the same slide, right? And after that we will move to bone marrow cancer and the classifications and their drugs, right? So okay, and also I will give you some mnemonics to remember to make things easy, right? So I think we should begin, right? Okay, so I am taking this slide, right? Okay, so try to draw with me. It will make things easy, right? So okay, so I will label this diagram, and after that we will write which drugs we use in what cancers, right? So I am starting, right? Okay, so this I am labeling as brain tumor. Try to follow with me, right? Brain tumor. So the drug that we use in brain tumor is temozolomide. Temozolomide, right? For example, glioblastoma multiforme, that butterfly tumor, no? So in such type of brain tumors we use temozolomide, correct? Temozolomide. Okay, then there is carcinoma. Okay, I will, 1 second. Yes. Okay, so then there is carcinoma meningitis, right? Carcinoma meningitis, and the drugs that we use here is methotrexate. Methotrexate, right? And it is dihydrofolate reductase inhibitor, right? Okay, next I'm moving here. This is you know head and neck cancer, right? Head and neck carcinoma. Now for head and neck carcinoma we use cisplatin, and yes, right? Brain tumor we use temozolomide. For head and neck cancer we are using cisplatin, correct? Now just go downwards, and okay, so it is upper GI carcinoma, correct? Esophageal or gastric, whatever, upper GI, correct? So here we use cisplatin plus 5-fluorouracil, correct? Okay, now I am taking lung cancer, correct? Lung cancer. So in lung cancer the drug of choice is cisplatin, right? Lung cancer drug of choice cisplatin. Upper GI cancer cisplatin plus 5-fluorouracil, correct? Okay. All right, give me a second. Okay, yeah, so after that we are taking hepatocellular carcinoma, correct? HCC is hepatocellular carcinoma, right? So for hepatocellular thing we use sorafenib, correct? Okay, then let's take pancreatic carcinoma, correct? And here we use gemcitabine, correct? Then let's take urogenital cancer, urogenital carcinoma. Now in urogenital carcinoma, once again, yes, urogenital carcinoma, drug of choice is cisplatin. Drug of choice is cisplatin, correct? And I will discuss other tumors in a while, right, in a separate section. Try to follow, right? Like ovarian carcinoma. So in ovarian carcinoma you usually give taxanes, correct? Taxanes. For bladder carcinoma, gemcitabine, right? For testicular carcinoma we have the famous BEP regime, right? What is this BEP regime? See, it is bleomycin plus etoposide plus cisplatin, right? This is the BEP regime, correct, for testicular carcinoma, right? Okay. Now as you can see here, I made a bone, right? Okay, here I made a bone, correct? So this is your osteosarcoma, and drug of choice here is cisplatin, correct? Cisplatin, doxorubicin, right? Doxorubicin, then methotrexate. I am writing the short forms, right? Cisplatin, doxorubicin, methotrexate, ifosfamide, right? So you can make combination of any two regimes, correct? Any two regimes, correct? This and this is often preferred, but you can use any two regimes, correct? Okay, so other cancers, like I have to discuss separately, right? So we discussed lung cancer, right? Okay, yes. So okay, I will take a different slide. Okay, so in the diagram for renal cell cancer, correct, for RCC, drug of choice is bevacizumab, correct, or sunitinib. Sunitinib is common, right? All right. And then for adrenal gland carcinoma, remember VCD, correct? V for vincristine, right? C for cyclophosphamide, D for dacarbazine. All right. Now moving on to lower GI carcinoma, that is colorectal carcinoma. Now here drug of choice is your 5-fluorouracil plus oxaliplatin, right, or irinotecan, plus an important drug, folinic acid. This is important, right? And what we say as Folfox or Folfori regime, right? 5-fluorouracil plus oxaliplatin or irinotecan plus folinic acid, which is the Folfox or Folfiri regime, correct? And next, last probably anal carcinoma, correct? 5-fluorouracil plus topical mitomycin C. Yes. Last but not the least, and important, anal carcinoma, 5-fluorouracil plus topical mitomycin C. Overall, as if you see the chart, the most important drug is cisplatin. I will recommend you to write everything in that picture itself. I could not make it because of lack of space, right, in the screen. but try to make it itself in that chart, right? In that diagram only you can make it. So okay, and we will revise once. Okay, see, for head neck cancer, the drug of choice is cisplatin, right? I will start from brain. For brain tumor, it is temozolomide. For carcinoma meningitis, it is methotrexate, which is dihydrofolate reductase blocker. For head neck cancer, it is cisplatin, right? For upper GI cancer, cisplatin plus 5-fluorouracil, right? For HCC is sorafenib. For pancreatic carcinoma, it is gemcitabine. For lung carcinoma, cisplatin. For osteosarcoma is cisplatin, doxorubicin, methotrexate, ifosfamide, any two, right? For urogenital, it's cisplatin. For ovarian, taxanes, bladder, gemcitabine. Testicular CA, it is beprezim, bleomycin, etoposide, and cisplatin. For RCC, it is bevacizumab or sunitinib. For adrenal gland, it is VCD regime, right? Vincristine, cyclophosphamide, dacarbazine. For colorectal CA, it is 5-fluorouracil plus oxaliplatin or inotecan plus folinic acid, which is the Folfox or Folfid regime, right? For NLCA, it is 5-fluorouracil plus topical mitomycin C. Now you can notice that the most common or overall drug that is used in CA is cisplatin, right? Cisplatin. Now in future slides we will see what are the side effects of each drug, right? In one slide I will try to show. Okay, moving on. I think this much is clear, right? Okay, so bone marrow I will take you in the last part of the session, right? Let's discuss the side effects, right? So we will draw the same picture. Just draw it some way, okay? So we will start leveling, right? So first I will start with neurotoxicity. See, if we say about neurotoxicity, SIADH is caused by vincristine, right? SIADH caused by vincristine. Then cerebellar toxicity. Cerebellar toxicity, it is caused by cytarabine, correct? Cytarabine. Remember the drugs is important, right? As neurotoxicity, SIDH caused by vincristine, cerebellar toxicity by cytarabine, and GTCS is generalized tonic-clonic seizure or ataxia, right? This is caused by ifosfamide more than cyclophosphamide, correct? Remember this, right? This is under neurotoxicity, right? Next, if I say ototoxicity or maximum nausea and vomiting plus nephrotoxicity. Now this all is shown by cisplatin, and for this chemo-induced nausea vomit, the drug of choice is Ondem, or what we say as ondansetron, right? Remember it. Ototoxicity, maximum nausea, vomiting, nephrotoxicity, all these are caused by cisplatin, and for this chemo-induced nausea vomit, drug of choice is ondansetron, correct? Okay, now let's go here. I will say peripheral neuropathy. Now peripheral neuropathy, now this is the side effect of your three drugs. Basically this may be caused by cisplatin, may be caused by vincristine, may be caused by taxanes. So all these three drugs may cause this peripheral neuropathy. It is very important. So again I will repeat: peripheral neuropathy caused by cisplatin, vincristine, taxanes. Cisplatin, vincristine, taxanes, right? Don't forget. Exactly. Now here some related to bladder, right? Okay, so first is your hemorrhagic cystitis. Now hemorrhagic cystitis is caused by which drugs? Ifosfamide more than cyclophosphamide, right? And here the treatment of this hemorrhagic cystitis is mesna. Okay, remember this, right? Okay, now moving on. Let's say cardiotoxicity. Now, which are the chemotherapeutic agents that are cardiotoxic? See, doxorubicin, right? Donorubicin and trastuzumab. These show cardiotoxic effects. Doxorubicin, donorubicin, trastuzumab, correct? And now I will discuss the important this one, pulmonary fibrosis. Pulmonary fibrosis shown by bleomycin more than busulfan. Busulfan also shows pulmonary fibrosis, but bleomycin has maximum association with this pulmonary fibrosis thing, right? Now there is a derma condition, right? Like flagellate hyperpigmentation. Flagellate hyperpigmentation shown by usually at back, it is shown by bleomycin. It is a derma condition that is shown by bleomycin. So bleomycin has two effects, and this is important. One is it shows flagellate hyperpigmentation, and another is shows pulmonary fibrosis, right? Okay, and some other side effects I will write here, like your hepatotoxicity. Hepatotoxicity is shown by 6-mercaptopurine, or 6-thioguanine. These drugs show hepatotoxicity, also shown by methotrexate, right? And imotinib. Remember these three drugs, with first two being the important hepatotoxic agents: 6-mercaptopurine or 6-thioguanine, methotrexate, imotinib, right? And then if we say that hand and foot syndrome, right? Hand and foot syndrome, right? Usually it is the disformation of palms and soles, and it is caused by, I will write here cause, also I will write here treatment. See, it is caused by capecitabine more than 5-fluorouracil. Remember this one, 5-fluorouracil, right? And if possible, remember both, capecitabine more than 5-fluorouracil. Treatment is pyridoxine, or what we say as vitamin B6. Okay. And the last one is your bone marrow suppression. Important, right? So bone marrow suppression is shown mainly by methotrexate or its derivative, this pemetrexate. Methotrexate or pemetrexate shows bone marrow suppression, and the treatment is folinic acid, also known as folinic acid or leucovorin. So this acts as a rescue, right? So this is the treatment, and this is the cause for bone marrow suppression. So we have discussed the important points, right? Now I will go to the bone marrow agents, cancer treatment agents, right? Okay, before that I will like to tell you something about this one. See a breast here only. Okay, so one is if it is ER positive, one is if it is your HER2 positive, right? And one triple negative. Okay. So if the case is ER positive, right? So we can divide it as premenopausal or postmenopausal. Okay. Drug of choice is mainly tamoxifen. Okay, tamoxifen is the drug of choice. For HER2 positive, drug of choice is trastuzumab. Remember, this is enough. And for triple negative, we will like to give cyclophosphamide or taxanes, right? For ER positive, tamoxifen. For HER2 positive, trastuzumab is important, and for triple negative, cyclophosphamide, taxanes, right? Okay, now we will move to this one. Yes, bone marrow carcinoma. So remember the mnemonics which I already mentioned here. This will make things easier, right? Okay. So bone marrow CA, we can divide it into leukemia, lymphoma. Now here again, leukemia may be acute, chronic. Discussing about acute part, there is AML, LL, acute myeloid and acute this one, right? So for AML, these two drugs, CD. So for C it is cytarabine, and for D it is daunorubicin, right? So these two drugs. So let me write for you. This is cytarabine plus daunorubicin. You can remember as CD. For AML it is CD, cytarabine plus daunorubicin, right? For ALL it is VPAD, right? VPAD. So VPAD stands for V for vincristine, correct? P for prednisolone, right? A for asparagine, and D for same daunorubicin. So this is the treatment part for ALL, correct? VPAD, vincristine, prednisolone, asparagine or asparaginase, daunorubicin, correct? And for CLL it is FCR regime. FCR stands for fludarabine, C for cyclophosphamide, R for rituximab. Fludarabine, cyclophosphamide, rituximab for CLL, correct? Now CML is very important. For CML, drug of choice is imatinib. This is the first generation, right? If imatinib is non-responsive, we will go for dasatinib, right? Dasatinib, nilotinib, bosutinib, right? So these are the drugs which are usually tyrosine kinase inhibitors, right? So remember, drug of choice imatinib. If non-responsive, dasatinib, bosutinib, nilotinib, right? These are the drugs, right? Okay. For Hodgkin's, and yes, now it is lymphoma. So lymphoma, there is Hodgkin's, non-Hodgkin's. For Hodgkin's, we give the famous ABBD regime, where A is for adramycin, B for bleomycin, B for vinblastine, D for dacarbazine. I repeat, A for adramycin, B for bleomycin, B for vinblastine, D for dacarbazine. ABBD regime. Non-Hodgkin's, there is low grade or high grade. For low grade, it is FCR regime, and high grade, it is chopper regime. FCR I already mentioned, that only, and high grade is chopper regime. So chopper I will write. This is also important. Right? So I will write the non-Hodgkin's chopper regime part, right? Okay. So this I am continuing here. So chopper. Okay. So C is for cyclophosphamide, H for hydroxydoxorubicin, C for cyclophosphamide, H for hydroxydoxorubicin, right? O for oncovin, P for prednisolone, and R for rituximab. So this is your regime: cyclophosphamide, hydroxydoxorubicin, oncovin, prednisolone, and rituximab. So with this, I completed major portion of your anti-cancer drugs. I hope this session will be helpful for you. For more such sessions, you can join my channel where I upload these things, right? So it will be helpful for your exams. I take regular sessions only. So I hope you will join, right? Thank you for connecting. Bye.